So arteriosclerosis is going to be a thickening or hardening of the arterial wall. It is associated with aging. Atherosclerosis is a type of arteriosclerosis. Sorry guys, these are a mouthful. So atherosclerosis is going to be a plaque formation within the arterial wall, and it is the leading risk factor for cardiovascular disease. So this is going to be showing you what a normal artery looks like, a mild, an artery with mild atherosclerosis, and then obviously the artery on the far right has severe atherosclerosis. So, for atherosclerosis, the pathophysiology is unknown. Blood vessel damage causes inflammation. This allows a fatty streak to appear on the inner lining of the blood vessel, and then a fibrous plaque is going to be formed. So, a couple of different types. We have stable versus unstable. So, what happens next? The plaque becomes stable or unstable. So, with stable plaque, it is a fibrous elevation. With an unstable plaque, it has a liquid core. These lead to occlusion and decreased blood flow. Some factors affecting plaque buildup. There is a table in your book. It's on page 707, table 36-1, that discusses these risk factors. So genetics, chronic diseases such as diabetes, smoking, diet, and exercise. All of these affect plaque buildup. So which is worse when it breaks loose? That's going to be the unstable. So when a stable plaque ruptures, it causes inadequate perfusion or oxygenation. When an unstable plaque ruptures, it causes ischemia or MI. It is prone to rupture, and it's often clinically silent until it ruptures. So that's what makes it more dangerous. So for your assessment here, you are going to monitor your vital signs. You want to do vital signs in both arms. Why do you think this is? This is going to be related to a high incidence of hypertension is common. So pulses, there is a nursing safety alert on page 708. The pulses in the skin, you want to look for signs and symptoms of poor circulation. So these are going to be prolonged capillary refill, cool skin, and then a comparison of the pulses that may be different. The nursing safety alert shows that decreased intensity or loss of pulse may indicate arterial occlusion. This must be reported immediately. It's an emergency. Bruits may be present. They are always abnormal. So these are going to be a turbulent or swishing sound. Carotid, aortic, femoral, and popliteal arteries are where you're going to listen for these bruits. Your laboratory assessment, your serum cholesterol should be less than 200. Your LDL, which is your lousy, is going to be less than 130 for healthy people or less than 70 for patients with cardiovascular disease or diabetes. Your HDL or your healthy you're going to want it greater than 45 in men and greater than 55 in women. We talked about this in the last chapter, I believe, and I think the number was a little bit different. Don't worry about these numbers, guys. I don't expect you to know them, just for general purposes. It's for you. So high LDL and low HDL are going to increase the risk for atherosclerosis. And then your triglycerides, they should be less than 160 in men or less than 135 in women. There is a table 36-3 on page 709 that discusses primary and secondary prevention for hyperlipidemia. Some interventions you want to look at: nutrition. You need to make sure they're a healthy weight and they have a low fat, low sugar diet. Physical activity is very important. It is suggested that you have aerobic activity 3 to 4 times a week. It needs to be 40 minutes per session, and the activity should be moderate. It should be a vigorous activity. So some drug therapy, statins. These are going to be lovastatin, simvastatin, atorvastatin. Those are just a few. These reduce cholesterol synthesis in the liver and increase clearance of the LDL from blood. The lower LDL and triglyceride levels, they also do that. And then there's a nursing safety alert on page 709. So very, very important, guys. Statins are contraindicated in patients that have active liver disease. You need to know this. Also, these patients that take statins need to avoid grapefruit and grapefruit juice. Zetia is another drug. It inhibits the absorption of cholesterol through the small intestines. Vytorin is going to be a combination drug. It reduces the amount of cholesterol synthesized and and reduces the absorption of cholesterol. Some other combination drugs are going to be Caduet, Niaspan, and Omacor. For hypertension, so blood pressure and age are correlated. Some risks are going to be stroke, MI, kidney failure, and death. So with blood pressure for those older than 60 should be less than 150/90. Blood pressure for those less than 60 years old should be less than 140/90. Blood pressure regulation. So arterial baroreceptors are going to assist with this. These are found in the carotid sinus, aorta, and the wall of the left ventricle. So you want to monitor arterial pressure, and arterial baroreceptors fail in hypertension. So they counteract increased pressure by slowing the heart and vasodilation, and in hypertension this does not happen. Your fluid volume, you've got sodium and water to think about, diuresis, and the renin-angiotensin-aldosterone or RAS system. So your blood pressure rises related to excess sodium and water in the system, and adequate kidney function causes diuresis in response, which decreases the blood pressure. Your RAS system, so your kidney produces renin, angiotensin 1 forms, angiotensin 1 becomes angiotensin 2, vasoconstriction is going to occur, aldosterone is released. So aldosterone is going to cause your kidneys to retain sodium, and your body retains water to dilute the salt in response. Again, your blood pressure rises. Vascular autoregulation, it keeps perfusion in the body stable. This is important in causing hypertension, but they don't really know how. The mechanism is unknown. They do know that it plays a part, though. So tell me, why is my BP high? So essential hypertension is the most common. It is idiopathic, and it has several risk factors. So you've got family history, sedentary lifestyle. Your diet is typically high sodium, high calorie. Obesity, smoking, RN school, or stress. Excessive alcohol intake. Age greater than 60 plays a role. And African Americans have a higher incidence of essential hypertension. Now then, there's secondary hypertension. This is going to be related to disease or drugs. It may be contributed to renal disease, aldosteronism, pheochromocytoma, Cushing's disease, coarctation, brain tumor, encephalitis, pregnancy, and medications. So malignant hypertension, severe elevated blood pressure that progresses rapidly. Symptoms are going to be morning headache, blurred vision, dyspnea, and uremia. Some signs are going to be your systolic pressure is greater than 200 and your diastolic is greater than 150. Prompt intervention is necessary to prevent kidney failure, left ventricular heart failure, or stroke with malignant hypertension. Obviously, those pressures are pretty high. So let's talk about some health promotion. Lifestyle changes, diet, eating out. So lots of people eat out a lot. It's convenient. Who has time to cook, right? So very important. You guys do need to know this. You need to educate your patients on low sodium choices when they are eating out. So maybe they don't know that low sodium is even an option, or maybe they just don't know what low sodium means. You need to educate them. Low fat, salt, and sugar diet should consist of that. Exercise. They need to encourage weight loss if their BMI is greater than or equal to 25. Again, that puts them in the obese category, ranging up to even morbidly obese. You want to make sure they know avoid alcohol. So less than or equal to 1 ounce. It's pretty conservative, but the purpose of that is they know they can't get, raging drunk every night and it's going to be healthy for them. That's false. And then smoking. Again, smoking plays a huge role in these cardiovascular issues. So some drug therapy, diuretics may be used. Thiazide, loop, and potassium sparing are available. So you've got calcium channel blockers, which cause vasodilation, which lowers blood pressure. ACE inhibitors, which block angiotensin conversion from 1 to 2. ARBs are going to block angiotensin 2 from binding. Aldosterone receptor antagonists are going to block aldosterone from binding. Your beta blockers block epi and norepi from binding. And then your renin inhibitors prevent renin from causing vasoconstriction. So there is a chart, 36-1, on pages 715 to 716. You may want to review that. Some helpful hints for you guys to remember. There's a little poem type thing that I found. So prissy prills get all A's. Those are going to be ACE inhibitors. Lisinopril, monopril. Olol get B's, beta blockers. So labetalol, propranolol. Cal pines for his girlfriend. Calcium channel blockers. Amlodipine, felodipine. And then the sartan arbitrarily beats his camel. So that's going to be your ARBs, low sartan. I don't expect you to know all of these drugs, but once you guys are probably mostly all out there working, but these are going to be drugs that you're dealing with consistently, so it may just help you to remember them. So, treatment barriers. Why do some patients quit taking their blood pressure medications? So, this is a prime example. Someone in my family. So they take their medications and their blood pressure returns to normal because they're monitoring it all the time to make sure that it works, right? And then they think, oh, my blood pressure's normal. I don't need to take my medicine anymore. That's a problem. The blood pressure is normal because you take the medication. So I know it sounds really basic, but to some people it's not. It's very important that you educate them on that. Also, they may forget to take the medicine, so that's not very uncommon. If you're not used to taking medication, it can be hard to get into that routine. Cost is a huge barrier. This is something that we deal with all the time in the hospital. Medications can be very expensive. Not everybody has insurance. Not everybody has the best insurance. Whatever the case is, cost can be a big barrier. And then impotence, obviously men don't like that very much, so they don't want to take the medicine. This is problematic. So, community resources, these are going to be very important for these patients. You want to make sure that they have support. If they don't have it at home, they can get it in the community. So again, make sure that you get them all the support that they need to try to ensure compliance with their treatment plan. Alright, so now we're going to start talking about some disorders. So peripheral arterial disease, or PAD, this is partial or total arterial occlusion. It decreases perfusion to the extremities. It is a chronic condition that results from systemic atherosclerosis. And PAD, what it does is it lowers, the lower tissues are going to be deprived of oxygen and nutrients because of occlusions. So obstructions are going to be either inflow or outflow. Basically, the only difference between these two is the arteries that are involved. So inflow has certain arteries, outflow has different arteries. So not a huge difference with those, just location basically. So with inflow obstructions, you're going to have pain in the back, buttocks, and thighs. With your outflow obstructions, you will have burning or cramping in the calves, ankles, feet, and toes. So you can see those are obviously upper legs, and then also lower legs for outflow. So some key features for PAD. You've got a couple of different stages. There is a chart on chart 36-3 on page 719. Someday, I promise, guys, I'll get it right. That is going to go over into these different stages. So, stage 1, you have no claudication, and your pedal pulses may be weak or absent. Stage 2, you've got symptoms that occur with exercise that are relieved with rest. And there may be intermittent claudication. Stage 2, you've got pain, cramping, or burning. Again, that's going to be relieved when they rest. Stage 3, the pain occurs at rest and is relieved by placing the extremity in a dependent position. So that means below the heart. The distal portion of the extremity is going to be where this pain occurs. So it's going to be the toes, the arch, the forefoot, or the heel. And it may be numbness, burning, or a toothache type pain, that gnawing type pain. And then with stage 4, you have necrosis and gangrene. So, very important with peripheral arterial disease, you need to know that you have claudication and you have ulcers. Okay? So, assessment. You are going to be looking for hair loss, dry, scaly skin, some thickened toenails, pallor when the extremity is elevated, and rubor when the extremity is lowered. This is also very important for you guys to know. Rubor is a classic sign and symptom of arterial insufficiency. Know that. Pulses. Your posterior tibial pulse is going to be the best indicator. This is because sometimes the dorsalis pedis is not present on every person. So you also want to make sure, once you find the pulse, that you compare the pulse strength bilaterally. This is important to telling you how severe that occlusion is. And then ulcers. These are going to be small and round. They have a punch-out appearance, and what that means is they have well-defined borders. So it looks like you maybe went in there and cut a circle out. It's not going to be irregular. It's going to be very well-defined on those. Some non-surgical treatment for peripheral arterial disease is going to be exercise. This improves the blood flow and circulation. So you want to exercise until you have pain, rest, and then exercise some more. Eventually, this is going to allow the patient to walk farther because their collateral circulation is going to begin to develop. So, who should not exercise? Patients that have severe rest pain, venous ulcers, or gangrene should not exercise. Positioning, you want to avoid elevation above the heart. So, a couple of things you really need to know. Nursing safety priority, page 722. The patient needs to avoid leg crossing and restrictive clothing because both of those are going to interfere with their blood flow. Know that. Vasodilation. You want to avoid heating pads, exposure to cold, and smoking. Know that heat is a concern related to their decreased sensitivity. That's important to understand. Some drugs, we've got pentoxifylline, don't know if I said it right, sorry y'all, aspirin, and then clopidogrel or Plavix, sorry. So you're going to give hemorrhagic and antiplatelet agents. These are going to increase the flexibility of the red blood cells and they decrease blood viscosity. Some procedures are available. So you've got percutaneous transluminal coronary angioplasty or PTCA. This is a big fancy word. Basically, they're going to go in and balloon and stent the arteries. Atherectomy, rotoblator, kind of a terrifying name for a surgical device, but it's called a rotoblator, and that goes in and scrapes plaque while protecting the vessel surface. So it's going to eliminate that plaque from that artery, but it's also not going to damage the blood vessel. And then arterial revascularization, you've got grafts, and again, it's going to be dependent on inflow and outflow. So your inflow are going to be occlusions that are above the superficial femoral arteries. These procedures are more successful. Outflow procedures are going to be dealing with occlusions at or below the superficial femoral arteries. And obviously these are going to be a little bit less successful. Alright guys, so this is that terrifying rotoblator. I'm not really sure. I think you'd probably have to be pretty skilled to get in there and get that nasty yuck out while protecting the blood vessel, but I'm sure they do it. And then underneath, that's going to be the PTCA, where they go in and balloon and leave the stent. Figures 36-5 and 36-6 on page 723 in your book show bypass grafting. It's kind of cool, so you may want to check it out. Okay, so revascularization. Look at the nursing safety priority on page 722. So post-op care, you want to make sure you're monitoring for bleeding. So some signs and symptoms you're going to be looking for is falling blood pressure, increased heart rate, decreased output, and you're going to be doing those pulse checks. Your graft patency, so when is the graft most likely to occlude? There's another nursing safety priority on page 724, but the graft is most likely to occlude within the first 24 hours. So you really want to be watching that first day post-op for reocclusion. So, what are some signs and symptoms of graft reocclusion? This is going to be pain. Pain may be the first indicator of graft occlusion. Know that. Okay, so if they have pain and they've just had this procedure, you need to make sure that you notify the surgeon immediately. Throbbing pain may be caused by increased blood flow to the area. So that's a little bit different. Throbbing pain is going to be a little bit different, and it may be normal than just generalized pain. Okay. Compartment syndrome. You want to monitor for increased pain, fullness, swelling, or tenseness. And what are you going to do if you suspect compartment syndrome? Obviously, you need to notify the physician immediately. A fasciotomy may be required for your patient, so very important to notify the physician. So, acute peripheral arterial occlusion. So, pathophysiology. What is the most common cause? The most common cause is going to be an embolus. Some signs and symptoms. You want to look at the 6 P's of ischemia. So you've got pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which that's going to stand for the temperature. Big fancy word for temp. Treatment is going to include heparin, thrombectomy, or embolectomy. And there is a nursing safety priority on page 725 you may check out. So most patients have had an acute MI or AFib or both within the last few weeks of this acute peripheral arterial occlusion occurring. Aneurysms. All right, so an aneurysm is the dilation of an artery. It is most commonly going to occur in the abdominal aorta. Figure 36-7, page 726, shows you some common anatomic sites of aneurysms. I thought that was pretty interesting. I didn't know there were so many. So there are some different types of aneurysms. You've got saccular, which is going to be an outpouching. Fusiform, which is going to be circumferential. And then you've got dissecting, where there's blood accumulation. Okay, so you can see the pictures on the right there. Your assessment, these patients are commonly asymptomatic. It's kind of terrifying because these are some pretty big vessels that are rupturing, or having aneurysms form. So your AAA, your abdominal aortic aneurysm, very, very important for you to know. Remember this, guys. You may find abdominal pulsation, systolic bruit, and the patient may feel a heartbeat sensation in their abdomen. So abdominal flank or back pain, and again the pulsation or bruit. If expansion or impending rupture of the AAA is suspected, you need to assess for sudden onset of severe pain in the back or lower abdomen. The pain may radiate to the groin, buttocks, or legs. Obviously, this is a huge emergency because these people can bleed out fast. So, big thing to be cautious of. Thoracic aortic aneurysm, or TAA. They may have back pain, shortness of breath, hoarseness, and dysphagia. If sudden rupture is suspected with a TAA, you want to assess for sudden excruciating back or chest pain. Some complications of the TAA: rupture is most frequent, life-threatening, obviously, again, because the abrupt and massive hemorrhagic shock, and emboli in distal arteries may occur. All right, so some interventions for aneurysms. Non-surgical management, you're going to monitor the growth and maintain the blood pressure. Blood pressure is important. You want to make sure that you treat hypertension to decrease the rate of enlargement and the risk of early rupture. Some surgical management, you've got AAA resection, TAA repair, or endovascular repair. Elective surgery is suggested if the patient is experiencing symptoms. So this is just a picture for y'all to check out. So you've got normal anatomy, and then on the right there you can see the abdominal aortic aneurysm, the eventual condition, and then you can see your correct surgical repair. So the defective portions of the aorta are going to be replaced with a synthetic graft. Post-op care for these patients, very important. AAA resection. You want to monitor for MI. Obviously, you don't want that happening. Graft occlusion. You can monitor for this by watching for a change in the pulse. Cold extremity below the graft. White or blue extremity or flanks. Severe pain, abdominal distension, and decreased output. Important. You want to monitor for rupture. Obviously, that's going to be pretty serious. Hypovolemia, respiratory distress, and paralytic ileus. With your TAA repair, you're going to be looking for hemorrhage, ischemic colitis, cerebral or spinal cord ischemia, respiratory distress, and dysrhythmias. Teaching. Post-op activity restrictions. This is important. You guys need to know this. No heavy lifting or driving, and no vigorous pushing or pulling. This activity restriction may be in place for 6 to 12 weeks. So obviously it is very important, if it's not an emergency surgery, if it is elective, that these patients have a good understanding of what post-op is going to look like. Wound care is going to be important, and pain management is going to be important. So for their health, you want to make sure they understand the need to have a follow-up CT. You want to make sure that your intervention is successful. Blood pressure maintenance, again, you want to monitor that, monitor and treat hypertension to decrease the risk of rupture. And then signs and symptoms to report. Nursing safety priority, page 727. I know you guys are so sick of hearing that. But the signs and symptoms to report are going to be abdominal fullness or pain, back pain, chest pain, shortness of breath, dysphagia, and hoarseness. Alright, so aneurysms of the peripheral arteries. Popliteal is going to be a pulsating mass that's seen in the popliteal space. Femoral, pulsatile mass over the femoral artery. Signs and symptoms will include limb ischemia, diminished or absent pulses, cool skin, and pain. Very important to understand, common sense, but I gotta say it anyways, never ever ever palpate the masses because it obviously is going to pose a greater risk for rupture. Don't be feeling up on them, okay? Alright, aortic dissection. This was previously referred to as a dissecting aneurysm. Really what it is, though, is a dissecting hematoma. So they changed it to aortic dissection. So this occurs when there is a sudden tear in the aortic intima. It is a medical emergency. It is highly lethal. Signs and symptoms include tearing, ripping, or stabbing pain, diaphoresis, nausea, vomiting, faintness, apprehension, decreased or absent peripheral pulse, and treatment. Okay, so aortic dissection is contributed to hypertension. The circulation of any major artery arising from the aorta can be impaired. So again, highly lethal medical emergency. Treatment for the aortic dissection will be pain and blood pressure management, and it may require surgery, which would be cardiopulmonary bypass. So this is an example of the aortic dissection. So you've got the aorta, inner layer of the aorta, you've got the tear that's in the inner layer, the blood that is filling into the artery wall, and then the blood where it's supposed to be in the normal artery opening. So again, very serious. This is another picture, aortic dissection. So it's just showing you again, you've got blood where it's supposed to be in the artery, and then you've got blood where it's not supposed to be in the wall of the artery. Okay, so some other arterial health problems. These are listed on table 36-7, page 729. I don't expect you to know all of them. Matter of fact, I had never even heard of all of them. Maybe I have just lived in a hole. I don't know. The only one I'm familiar with is Raynaud's disease, and that is the one that you are expected to know. So be sure you know it. So there's Berger's disease, Raynaud's disease, which is what the pictures on the right are from. So you want to make sure that you teach the patient with Raynaud's to wear warm clothing when they are exposed to cooler temperatures to prevent complications. The patient may also be prescribed vasodilators. Remember, you need to know all this. So in the picture, you've got the white skin is going to be related to a lack of blood flow. The blue skin occurs when the vessel dilation occurs to keep the blood in the tissues, and then you get the red skin as the blood flow returns. Some other arterial health problems, subclavian steel and thoracic outlet syndrome. Again, I just expect you to know Raynaud's. Peripheral venous disease, switching gears a little bit here. So, venous thromboembolism, or VTE. So a thrombus is a blood clot. What is the difference between a thrombus and an embolus? Okay, so the thrombus is a clot, An embolus is anything that travels through the blood vessels and it eventually will cause an occlusion. So you've got thrombophlebitis, which is a thrombus that's associated with inflammation. Phlebothrombosis, which is a thrombus without inflammation. Deep vein thrombosis, or DVT, this is going to be the most common, poses a great risk for pulmonary embolus. It is most commonly seen in ortho and prostate surgeries. It is increasingly found with central device use. Kind of scary, as prevalent as central devices are. And then you've got phlebitis, which is just going to be vein inflammation. So, your VTE, thrombus formation results from Virchow's triad. This is going to be stasis of blood flow, endothelial injury, and hypercoagulability. So some risk factors, these include surgery, ulcerative colitis, heart failure, cancer, oral contraceptives, immobility, phlebitis, and smoking. Very important to know that the presence of multiple risk factors causes an even greater risk to the patient. Oral contraceptives and smoking, for example, are common combinations that put women at a greater risk. Know it. Prevention, anticoagulation, avoid PO birth control, fluids, leg exercises, TED hose, SCDs, foot pumps, and ambulation. Just a side note, foot pumps, I had no idea what they were, so I looked them up. Never heard of them, never seen them. It's basically an SCD, except for it goes on the foot instead of the calf. So there you have it. Maybe you learned something, maybe not. Alright, so assessment. Classic signs and symptoms of DVT. What are they? You've got calf and groin tenderness and pain and unilateral leg swelling. There will be an induration or hardening along the blood vessel, warmth, edema, and redness. So Hohmann's sign, what is it? Hohmann's sign is when calf pain occurs with dorsiflexion of the foot. This is actually no longer recommended because it's unreliable. Venous duplex ultrasonography is going to be the preferred diagnostic test. And then you can also do a D-dimer. So if the D-dimer is negative, DVT may be excluded without ultrasound. Didn't know that. I thought that was interesting. Non-surgical management, you've got rest and elevation. So what about bed rest versus ambulation? This is controversial. Research suggests actually that there is no difference in the outcomes among those that are placed on bed rest and those that are allowed to ambulate. I thought that was interesting. What about massage? You do not want to massage the affected extremity. This helps prevent the thrombus from dislodging and becoming an embolus. Obviously, we don't want that. Heparin, different kinds of drug therapy here. Heparin, you've got a nursing safety alert on page 731. So it prevents the growth of the existing clot and formation of new clots. Okay? Your lab that's going to be associated here is PT, APTT, INR, CBC, UA, GUAC, and creatinine. So you're going to be monitoring everything for blood. Their UA, their GUAC. Want to make sure they're not bleeding anywhere they're not supposed to be. Very important for test purposes. Therapeutic APTT should be 1.5 to 2.5 times the control value. You don't have to know the value, you just need to know 1.5 to 2.5 times the control value. Also, you want to make sure that you monitor with heparin for heparin-induced thrombocytopenia. This is a big concern. And I've actually seen it several times, and it's typically not caught in my experience. So, make sure your patients that are on heparin, you're checking their platelets, okay? Same with Lovenox. Lovenox is the preferred treatment, and it's also preferred for prevention. Warfarin, you want to have frequent monitoring of the INR. So Very important for you to know, again, patients in the hospital, they're getting heparin, okay? Then they start taking warfarin while they're still on heparin. Are you alarmed? Absolutely not. Warfarin is going to take a while to get into the system to a therapeutic level. So, the patient is still going to be receiving that heparin until the warfarin reaches the therapeutic level. Then they will stop the heparin. You want to assess all patients, obviously, for bleeding. Chart 36-7 on page 732. And you've also got nursing safety alerts on page 731 and 732. Very important, guys. What are your antidotes for heparin and warfarin? Okay. Antidote for heparin is going to be protamine sulfate. Your antidote for warfarin is going to be vitamin K. You need to know those. So for surgical management, you've got the thrombectomy, which is going to be a rare procedure. Or you've got the vena cava filter. This is used for recurring DVT or for those patients that cannot take anticoagulation therapy. So the vena cava filter traps emboli to prevent progression to the lungs. Teaching. Obviously, drug compliance is going to be a huge deal. You need these people to take their medication. Dietary advice, very important. So Coumadin, what do they need to avoid? Avoid leafy greens. They're full of vitamin K. Follow-up monitoring is going to be the INR. And then adverse drug reactions or interactions. Bruising is an issue. Activity limitations obviously are in place. You don't want the person out there playing contact sports while they're on anticoagulation therapy. Chart 36-8, page 733. I knew you were waiting for it. You can look at that to get some more information there. Venous insufficiency. So, this results from prolonged venous hypertension. Valvular damage leads to edema and decreased tissue perfusion. Then, this results in venous stasis ulcers, swelling, and cellulitis. Some signs and symptoms, you've got stasis dermatitis and you've got stasis ulcers. So, stasis dermatitis is going to be the reddish-brown discoloration along the ankles and up the calf. Stasis ulcers, remember I told you previously, differentiation between the types of ulcers. With stasis ulcers or venous insufficiency, they're going to have irregular borders. They're not going to have that punched out appearance like arterial insufficiency ulcers do. Treatment. Non-surgical treatment. You've got prevention, obviously going to be important. Want to make sure that you heal the ulcers, so wound care specialists are often involved. And you may have some chemical debridement going on. You want to make sure that you prevent infection. So Una boots can be used to do this. They kind of provide a sterile environment. And then antibiotics can be used. And prevention of stasis. This is going to be really important, guys. So you've got elevation, TED hose, SCDs, and Una boots. You need to know if they're wearing compression socks or TED hose. They need to be applied before they get out of bed in the morning, and they get removed before they get into bed at night. So they have the night off, they wear them all day. Lifestyle changes, very important. You want to make sure they understand the need to change their diet, and physical therapy may be prescribed. And again, emotional support is going to be important for this population. And your surgical treatment, is going to be debridement of those ulcers. Alright, varicose veins. Everybody loves those, right guys? So these are going to be distended, protruding veins. The vein wall weakens and dilates. This leads to valve incompetence, which then causes venous reflux, and your veins become tortuous and distended. So bulging, edema, feeling of fullness, pain, pruritus, or itching. Venous stasis ulcers, you may have that brown pigmentation, which is also called staining. And ultrasonography diagnoses varicose veins. Look at those. Aren't those gnarly? So, non-surgical treatment is going to include compression stockings, elevation, exercise, laser therapy, and then you've also got surgical treatment, which includes ligation or removal. This is called stripping. And you've got sclerotherapy. You need to know about sclerotherapy. So what occurs with sclerotherapy is an agent is injected that occludes the affected vessel. So this is going to be an example. We've got pre-op on the left. Obviously, you've got those big distended tortuous veins. And on the right, the leg is looking much better. That's it for this one, guys. You're being so very patient with me. I know it's got to be hard, but I appreciate you anyways.